But based on the results of the Plato trial, I would probably lean more towards ticagrelor as long as there's no affordability issues for the patient. Now, for patients who receive fibrinolytics, and we don't use a whole lot of fibrinolytics anymore, simply because most patients live within range of a center that can do percutaneous intervention. However, if they were to receive fibrinolytics, they should receive, this is one time that they should receive clopidogrel on top of their aspirin. Ideally for 14 days, but I mean, they should receive it for 14 days, but could continue on up to 1 year afterwards. Now, in your general ACS patients that receive stents, it's kind of, you can receive either clopidogrel, prasugrel, or ticagrelor. But the guidelines recently changed where they give a reasonable preference, as they say it, again, slightly different than European guidelines, to prasugrel and ticagrelor. Again, based upon the results of the Plato trial, and then also the Triton-TIMI 38 trial, which showed that prasugrel had better outcomes than clopidogrel itself. So it basically, unlike the Europeans, again, which give preference, they label it as being as reasonable. Another change to the guidelines that took place is in patients that receive drug-eluting stents, particularly now that we're into using not first-generation drug-eluting stents anymore, where we had a lot more issues with very late stent thrombosis. The recommendation is if a patient develops a high risk of bleeding, in other words, if they're put on an oral anticoagulant, or if they develop a high risk of severe bleeding, meaning they're having intracranial surgery, or if they develop overt bleeding, meaning they actually develop a bleed, then dual antiplatelet therapy can be stopped at 6 months. So, and then also in these patients, you have the option of going beyond the 12-month window based upon the results of the DAPT trial and then also the Pegasus trial. And then finally, in CABG patients, CABG is a little bit different in the sense that if a patient is stented before CABG, antiplatelet therapy, dual antiplatelet therapy is obviously stopped during CABG. But then, as in the post-op period, patients should continue to receive their dual antiplatelet therapy for the length of time that was already decided if they had received PCI and a stent in the past. If they were just treated with CABG without actually being stented before, then the recommendation is to carry out dual antiplatelet therapy for 12 months and then continue aspirin for the rest of their life.